Hi,
Okay,
everybody. Hi, Dr. Goldberg. Hi, Dr. Nesher.
Hello.
We are very happy. We have great attendance already. Keep coming in, nearly 70 people. And we're going to start right away. Thank you, everyone, for joining us. Our distinguished guests, our board members, president of the board, our amazing supporters that are here, and of course, the staff that's helping and working so hard, even from home. So before, we have a very hot topic today, the future of COVID-19. We're not promising to know all the answers, but we certainly have questions, and we certainly have people that are in the cutting edge innovation with medical breakthroughs that can update us and inform us and discuss with us and answers some of our questions. So I'm gonna ask Executive Director of American Friends of Soroka Medical Center, Rachel Heisler, to please introduce the two guests. And before that, I'm gonna mute everybody. And when you talk, you please unmute yourself.
So welcome to Soroka Friends joining us today from around the world. We're thrilled to present the fourth session in our Ask the Expert series, where we provide participants with access to the world-class experts and provide vital information that we all need to navigate the global health crisis we are facing today. This series was initiated at the outset of the pandemic to share our experience at Soroka Medical Center. Thanks to the strong leadership and nimble coordination on the ground, Soroka swiftly responded in record time, building a standalone, isolated hospital for the testing and treatment of COVID-19 patients, utilizing state-of-the-art health tech elements. We are so proud that the innovation and science embedded in our COVID-19 unit has played a huge role for Israeli public health, and particularly benefiting the residents of the Negev. As we look ahead to the coming phases of this pandemic, we understand that the key to conquering COVID lays in testing, vaccination, and effective treatments, new, novel, effective treatments. We are actively engaged in research that will leverage our experience in conjunction with the scientists at Ben-Gurion University. Today's guest from Soroka will provide insight into what is currently in the pipeline. I'm honored to introduce two world-class experts. From Soroka in Be'er Sheva, we have Dr. Lior Nesher. Dr. Nesher serves as the head of the pandemic response team at Soroka Medical Center and leads the Infectious Disease Institute at Soroka University Medical Center. Dr. Nesher is a senior lecturer on the Faculty of Health Sciences at Ben-Gurion University of the Negev, and he has over 40 peer-reviewed publications. Fields of interest include translational research in rapid and high-throughput diagnosis of viral infections such as influenza and COVID-19, and the impact on clinical medicine and infection control performed in collaboration with Dr. Tomer Hertz at Ben-Gurion University Innovation Technology Research Center. He was raised in the US and is a graduate of the Goldberg Medical School at Ben-Gurion in the University of the Negev, trained in infectious diseases in the immunocompromised host at the University of Texas. From New York, we're proud to welcome back Dr. David Goldberg. Since he appeared in our debut Ask the Expert session, Dr. Goldberg has been immersed in caring for patients around the clock. Dr. Goldberg is an assistant professor of medicine at Columbia University Medical Center. He is an internist with Columbia Doctors, the faculty practice of Columbia University Medical Center, and sees his patients at New York Presbyterian Medical Group in Westchester. He graduated with high honors from Columbia University College of Physicians and Surgeons and completed an internship and residency in internal medicine, as well as a fellowship in infectious diseases, all at Columbia. Dr. Goldberg has been a beloved and trusted staple in the Scarsdale medical community for over 30 years. Board certified in internal medicine and infectious diseases, he has a special interest in travel medicine, Lyme disease, and other community-acquired infections. Again, working around the clock throughout this pandemic, treating hundreds of COVID-19 patients. Before we begin, I'm giving you a little teaser. We have a special guest with us here from Los Angeles who is going to speak to another of these most important and astounding potential treatments for COVID-19 that's currently in the pipeline. So we will introduce our special guest a little later. And now back to Pazit.
Thank you very much, Rachel. So without further ado, let's go to some of the questions and the discussions. So we got a lot of emails from people who are Soroka supporters, and we got also questions that people would like to ask themselves. We're gonna start with the hot topic. There's a lot of intense discussion surrounding anticipated vaccine, testing, and treatment. Can you each please, in a couple of minutes, give us a snapshot of the situation in Israel, Soroka, and in New York? Let's start with Dr. Nesher. Dr. Nesher, what's going on now in Israel in terms of anticipated vaccine, testing, treatment, and innovative breakthroughs?
So first of all, hello, and thank you all for having me come and talk. I'm very honored and happy to discuss and talk to everyone on the group. The situation, first of all, overall in Israel, the situation is pretty stable right now. Our illness is a far cry from what's going on in the US or in other countries in the world. We are very hardworking on a lot of rapid diagnosis and diagnostic features. We're also working on serology kits and trying to evaluate the means for identifying people who are immunized, immune, and so forth. Currently at our site, we don't have any active research on vaccine development, so I can't talk to that. However, this is a very difficult topic because we're not exactly sure at this point how much this disease enables the body to create antibodies and create such an immunity. And we're hearing, I'm seeing a lot of reports, and even from our testing, that we see many patients who have the disease and later on do not necessarily develop antibodies. We're not exactly sure at this point if this is due to lack of immune response or due to the kits and the tests and the different assays. So we're trying and attempting to look at different techniques of evaluating these antibodies, because the first thing you need to do is you have to see if the body is able to create antibodies, and the second phase is, do these antibodies actually develop immunity? There's a lot of discussion out there about herd immunity, but not necessarily all viral infections create immunity. So if there is no such immunity, then there'll be a very challenge on creating a vaccine. We may need to create a vaccine that will need to be given every year, such as the flu, and so on.
Okay, thank you very much. Dr. Goldberg, would you like to add and report from New York?
Yeah, first, thank you again for inviting me, and I agree with everything Dr. Nesher just said. There is tremendous uncertainty about the vaccine. We often hear people talk about 12 to 18 months until we have a vaccine. That's the minimum, not the maximum. It's a minimum of 12 to 18 months. We do not have any coronavirus vaccines of any sort so far. We don't know how easy or how difficult it will be to make one, and we don't know how effective it is. It's not necessarily black and white. The flu vaccine we give every year is about 80% effective on average. If we develop a vaccine that's 80% effective, to what degree will that open up the economy, open up our restaurants and the gyms, and all the rest? And we also don't know even how we measure the effectiveness of the vaccine. So we hope for one in 12 to 18 months, but there is tremendous uncertainty as to how effective it would be, how long it will take to develop it, how long the immunity will last, etc.
Okay, I'm going to, on that topic, I'm gonna ask some questions that we got from participants in email prior to today. Am I immune now? I had a lot of coughing for about 3 weeks back in January in New York, and I was very weak. I was too weak to go out, and it lasted about 3 or so weeks. I don't know if I had a fever, but I felt very weak. Does this sound like the coronavirus? And am I immune now?
So I think I'll take that question if I may. What we do know is that the body, when someone's infected with corona, after the disease, there is a very strong immune response. And the immune response creates several types and different types of antibodies. We have IgAs, we have IgG, we have IgM, and there's cellular immunity. Now, we do know that a lot of people after the immediate illness have a very strong and effective IgA response, which is an immediate response, and it lives within the airways, in the nose, in the pharynx, and so forth. So we do know from what has come out from China and from other countries in the world that for the immediate short future, the answer is if you did have corona, you probably are immune, at least for the short term. What we do not know is, does this translate into the memory cells of the body and into the long-term immunity, which is more of the IgG and cellular immunity? And is this immunity maintained long-term, meaning next winter, if you encounter the corona again, will you still be immune or will you be sick again? And that is the very essence of the area of uncertainty that we are facing right now.
So there's just another question here. Are 100% of people that had confirmed coronavirus have a positive antibodies right after?
No, the answer is no. And we don't know if that's because the ways that we measure the antibodies is not adequate, because our kits and our assays are not sensitive enough, or is it because they do not create the antibodies? IgA antibodies are found almost 100% in everyone, but those are the short-term ones. The IgGs and the IgMs, which are the one that gives you the immune system for the long term, we're not sure if the body creates them or if we creates them and we aren't able to measure them. That's the area of uncertainty that we have right now.
Dr. Goldberg, would you like to add anything about immunity?
Yes, just getting back to the original question, it's certainly possible that the cough that lasted for 3 weeks was caused by coronavirus. The only test that you can do now is to do an antibody test. If it's positive, then it's more than likely, not definite, but certainly very likely that you had a coronavirus, a COVID-19 infection. If it's negative, it's still possible it was COVID-19 because not everybody generates an antibody response. Part of the problem is we don't really know how good our tests are. There might be important antibodies out there that are generated by most people, which we aren't even measuring yet. So there's all we can say about people who had a coronavirus infection is that you probably have some immunity for the time being, but how long that lasts and how we can even determine it, we don't know yet.
Okay, and also about being contagious. How long after you recover from coronavirus are you still contagious?
The recommendation in the United States, and this is based upon very limited data, is that once you have felt well for 72 hours, that means 72 hours with no fever and almost no symptoms, the thinking is that you are no longer infectious at that point. If you have a little residual cough, that's thought generally not to be significant. However, there are really very limited data to support that. Many people simply ask to repeat the test. The first test that we do is a nasal swab to see if there's evidence of the viral RNA there, and a lot of people request a repeat test. The problem is that some people who feel perfectly fine after the illness still have RNA in their nose and they test positive. Are these people still infectious if they feel perfectly fine. We really don't know, and we're finding a number of them. So we're just not entirely sure, but the guideline as per the CDC is 72 good hours and you're no longer infectious.
I'll enhance on that, and I agree totally. Since we have a pretty much a very rapid throughput way of monitoring and performing PCR tests for a prolonged period of time, we see viral shedding that continues on to occur in a significant amount of people for up to 4 or 5 weeks, even after they become well again. However, it is totally unclear what is the meaning of this viral shedding. We know that many other viral diseases, people continue to have the RNA material in there. That does not necessarily mean that they're infected. What we do know is that the more sick you are, the more you cough, the more you sneeze, the more your temper, the more you pass around the virus around you, and there is a higher chance that you're infected. In Israel, at least, what we currently recommend is, even though people have become better for 72 hours, we still test them twice for RNA carriage and keep them in 14 days further on isolation. But we have the privilege to do that because we have a limited amount of people who currently are sick, and we're very strongly trying to contain it. So we keep on isolation measures for a much longer period of time than just 3 days. We add out to 14 days at least.
Right. So you're saying that comparing Israel with America, it's not really fair because it's not like comparing apples to apples. There is a lot of demographic and other issues, correct? There's a question here in the chat that is on the same topic. We have a lot within us right now, and we're having 92 people already. So we have a lot of people that have older parents or their parents and their grandparents. So they really are eager to see their extended family. There is a question: what is the protocol if we want to see our daughters, their husbands, and babies, grandchildren, after all of this time of in isolation? What process can we follow before we see our family? And what roles does testing play in this?
The recommendation in the United States would be 14, if you're isolated for 14 days, or quarantined, I should say, if you're quarantined for 14 days and you show no signs of illness, then you're generally thought not to be infectious. So if you and the two grandparents have been quarantined for 2 weeks, and if the children and grandchildren have also been quarantined, haven't been with anyone else, then it's probably okay for the two families to get together. There generally isn't much value in this situation of doing nasal swabs and checking people if they're asymptomatic. But again, I would just have to emphasize that that is not based on really strong data. There is concern that the incubation period might be more than 14 days. If you want it to be really safe, you might stretch that to 21 days.
Okay.
What happens in Israel, we went a bit more to the extreme. And first of all, I totally agree. There's no point in doing any swabs or testing because it's not very meaningful. But currently recommendation is Israel's are social distancing still to be maintained. Even if someone has no signs and no symptoms, we still maintain social distancing, especially with people above the age of 60, the grandparents and so forth. And it's very difficult and hard on the people, but we still try to encourage and maintain social distancing to try and keep things more under control. And people are recommended that even when they go and see the grandparents, to stay at least 6 to 8 feet away, even if they're totally asymptomatic and so forth. Just to, as I said, we're going a bit more to the extreme in Israel.
Okay, great. Let's go to the innovation, the breakthroughs, and the cutting edge science and medical breakthroughs that are coming on. So we have also a special guest with us, and I'm going to ask Rachel Heisler to introduce that special guest that has definitely very exciting feedback about medical breakthrough. Rachel?
Hi, I think I lost the video. Do you see me?
No, I can ask for your video.
Yeah, it got disconnected somehow, but I'm here. As long as you can hear me, we are good.
Okay.
And first of all, I want to thank our board member, Dr. David Farmars Kimiabash, and it's thanks to his leadership that we were introduced to Dr. Jay Lalazari and had the opportunity to invite him to join us today. Dr. Lalazari is a physician on the leading edge of investigating a new potential treatment for COVID. He's the interim chief medical officer at Cytodyne, a late-stage biotechnology company, and he's engaged in developing a drug called I can't even pronounce it, leronlimab, which is a novel treatment that is has been developed in conjunction with treatment of AIDS, and now, like so many other drugs that we're finding that are existing in the pipeline today, he is repurposing it and experimenting with using it with great results for COVID-19 patients. So we're very, very appreciative, and we'll, with no further ado, bring on Dr. Lalazari to introduce himself and his expertise further and tell us what he's been working on and his hopes for it. Thank you.
Great, thank you, Rachel. Good morning, everybody from San Francisco, not LA. And
oh, sorry.
That's all right, and I'm greatly relieved to hear that the situation in Israel is moderately under control right now. So thank you. And I'm still digesting what Dr. Nesher had to say about the longevity of our immune responses to coronavirus. So yeah, I think I do bring some good news to the conversation this morning. And the story is that leronlimab is a CCR5 monoclonal antibody that we've been developing for HIV for years now. By blocking CCR5, you block HIV entry. And the application is actually into the FDA. And the only important part of that story for this conversation is that 800 patients have been dosed with leronlimab, with HIV, and there has been no discernible safety signal at all. 2 patients had very mild injection site reactions for a couple of weeks. That's it. And some of those patients have been treated in our clinic for 6 years. So we and the FDA very comfortable with the safety profile of leronlimab. About 7 months ago, the data became available that in a mouse model of breast cancer, that leronlimab provided 100% protection against metastatic spread of CCR5 positive breast cancer. Based on that, we began a study with women who had triple negative breast cancer, whose tumor or the surrounding infiltrate were CCR5 positive. And the proposed mechanism of action was by binding to CCR5 on regulatory T cells, we can prevent their action in suppressing cellular immune responses in the tumor microenvironment. And by binding CCR5 on tissue macrophages, we switch them from MT2 to M1 phenotype, and that also hurts the tumors. So we started treating women with breast cancer, and we actually saw some pretty encouraging results with some tumors shrinking and, importantly, measurement in blood of circulating tumor cells. There were a couple of women who came onto the study who were 0 at baseline, but all the rest went to 0 within 3 to 4 weeks. And so that seemed to be providing some in vivo proof of concept of the proposed mechanism around regulatory T cells and macrophages. And that's when COVID hit. And Cytodyne, and in particular, Dr. Bruce Patterson, who is the laboratory genius that I have the privilege to work with, said, you know, if we're actually affecting macrophages and Tregs in cancer, we can do the same in COVID-19, particularly around the cytokine storm. So leronlimab certainly is not an antiviral. doesn't prevent transmission, would not be, it may be better with an antiviral, but it really is about the immunologic response to the virus. And our basic view has been that the virus makes you ill, but it's the immune system that kills you. And I think the general scientific community is coming around to that view. So we had submitted a couple of a push-pull with the FDA because they couldn't quite get their minds around it. They knew the drug was safe, and the women with breast cancer, again, the drug was safe, no issues. And eventually, they didn't even understand why we would want to try this approach. So they had us on 60-day hold and a lot of complaining. Later, they actually released the studies, and we have a phase 2 and a phase 3. The phase 2 is for mild to moderate patients. The phase 3 is for patients which are severe. Mild to moderate is short of breath. Severe is on oxygen in the hospital. In the meantime, and they did not give us a compassionate use program, which was very frustrating, which meant that any doctor in the United States who wanted access to the drug had to file an emergency IND application, which requires a phone call, protocol, consent form, IRB, the whole shebang for every individual patient. Fortunately, there were some doctors who were intrigued by the proposed mechanism and took it up. And in particular, at Montefiore Hospital, where my beloved father works, there was a doctor, Harish Sithamanju, who not only filed the individual treatment INDs on 10 critically ill ICU patients, 9 of 10 of whom were intubated, he also drew blood for us at baseline, day 3, day 7, and day 14. And what we saw in Harish's patients was amazing. Several of them were extubated within 48 hours. A couple came off blood pressure support. Overall survival in the first 10 was only 50%, but that's pretty good here in the US. And a lot of those patients were on hemodialysis already. Other centers have taken it up and started to use the drug earlier in patients who are on oxygen support, but before they're intubated. And we've seen that all but 2 of the patients have done well. The plural of anecdote is not data, but it's 36 patients now who have done well, including a number of patients who were either intubated or on ECMO. What is really exciting is that we saw the laboratory results in these patients. And first it was 4 out of 4, and then it was 7 out of 7, and now it's 10 out of 10. So the statistical probability that this is a fluke is almost 0. And what we saw, and that is now in the public domain, is very rapid reversal of, first of all, the severe immune suppression in patients who are critically ill. Their CD8% are single digits. So there's immune exhaustion of the CD8 lineage at baseline. And these patients are not only dying, of renal failure, and not only dying of cytokine storm, but they're dying of severe immune suppression. And what was amazing was by day 3, after a single subcutaneous dose of leronlimab, it's given weekly, it has a 200-hour half-life. At day 3, we started seeing reversal of the CD8 suppression. CD4 is also suppressed, but CD8 is more suppressed. So what we see is a gradual reversal or restoration of immune homeostasis based on CD4-CD8 ratio. Also amazing, we start seeing very rapid declines in the cytokines, particularly IL-6, but not only IL-6, at day 3. And, at first it was just 4, and then 7 patients, and now 10. And it's not ambiguous. It's not subtle. It is it's amazing. And I think the FDA has had a lot of trouble understanding how that is even possible. And frankly, at first we were kind of like, how could this be possible? The good news, and I can't share all of it because it's being submitted to Nature tomorrow, and will all be public next week, is that we have identified the cytokine that is driving this whole mess, that appears to provide an explanation for why a single dose of a CCR5 monoclonal could provide these kind of benefits. We now have data on immune exhaustion markers, which dovetail nicely with the CD8 story and reverse as well. And then finally, we just got viral load last night, which is also all fitting together in a nice little puzzle that shows that actually intervening, even in critically ill patients with leronlimab, can reverse the immune exhaustion, reverse the cytokine storm, and provide survival benefit, even at that late stage. And it seems intuitively obvious to me that if we then use the drug a little bit earlier, when patients are on the verge of severe immune suppression, on the verge of cytokine storm, that those benefits would be even more pronounced.
Dr. Lalezari, thank you so much. This is really, really exciting. I want to give the opportunity to the other two experts to ask you a question or react to what you're sharing with us, these exciting new breakthroughs. Dr. Goldberg and Dr. Nesher, what is your reaction to what you're hearing now?
Well, it's absolutely fascinating. Let me just take a step back for the benefit of the people who are not physicians. So there's two concerns that we all have about the COVID-19 infections. One is the direct damage that the virus does. The other is what we call cytokine storm. The body's immune system seems to overreact, and a lot of the damage that's done is by the body's own immune system. So there's two different types of treatment we're looking at. One is what we call antiviral agents. The one that we've heard the most about is called remdesivir, but it's still in the very early stages of treatment. And then you've got other treatments that will try to control this overreaction of the immune system. And the third aspect that I really hadn't heard about before this is that certain other parts of the immune system are actually overly suppressed. And so certain parts overreact and certain are suppressed, which I hadn't heard about before. That was very interesting. I guess the first question I have is the concern about using medications that might suppress the immune system is that might suppress this overreaction, is that there's concern that might allow the virus to replicate and advance. Do you have any ideas, even if they're preliminary, how do you identify which patients might be a candidate for a treatment like this?
Right, thank you very much. It's an excellent question and was a concern about using the drug too early. So if you had a patient who was infected but asymptomatic or very mild disease, could a CCR5 monoclonal antibody make the disease worse by suppressing immune responses? I think the answer is we haven't seen that. We've seen the exact reverse, immune restoration fairly rapidly. And now that we have viral load data to put the story together, it doesn't appear that we're delaying clearance of virus at all. In fact, the clearance of virus is tracking exactly with restoration of CD8 and bringing down the cytokine storm. We have begun reaching out to World Health Organization, the Gates Foundation, the Clinton Foundation, to start a conversation of what it would look to use this drug, not only in developed world, but around the world, and what patient populations we would think would be most appropriate. And obviously it gets complicated in different settings where they either have oxygen or don't, or have pulse ox or don't. My general feeling is that we're going to be using this drug in patients with anything more than mild shortness of breath, and that the treatment regimen for most patients will be 2 doses, one on day 1, one on day 8. Each dose is 2 subcutaneous injections. I think there are patients who could get away with 1 dose, which will make a difference in terms of the manufacturing supply. And I think that we're seeing that ICU patients, for reasons that I can get into next week if you want, some of them would be better off with 4 doses because of the persistent elevation of the cytokine that's driving the whole inflammatory mess. So patients with something more than mild to moderate, more than mild shortness of breath would be the patients I think are the most appropriate.
Thank you very much. Dr. Nesher, any comments?
Yes, actually very interesting, very fascinating information, and I hope it really does have an impact. Have you looked at all at the pronunciation of the CCR5 receptors? Because I know that there are different phases and different illness parts that the receptor is exhibited or is actually pronounced, and I'm sure it also has an effect on the activity of the drug. And
another great question. In fact, that is what hounded our HIV drug development, is that patients with acute illness would have upregulation of CCR5 expression. And so what was a therapeutic dose for 6 months or a year suddenly was not enough during their herpes outbreak or their flu illness. And that bedeviled us for years, which is partly why we kept increasing the dose up to now 700 milligrams once a week. What I can tell you is that looking at these ICU patients, if you look at, I don't know that we have measured their receptor expression before, but measuring receptor occupancy, that we're getting to 90% occupancy by day 4 or 5. And that again is completely tracking with all the other metrics. I imagine CCR5 expression is very high in these patients, upregulated, but we are, with the single dose of 700 milligrams, seem to be getting a very high receptor occupancy very quickly. One of the questions would be, should we give a second dose at day 3 in these critically ill patients? Should we try a higher loading dose? Those are all lovely questions that we would love to be in discussion with if we had an FDA that was in the mood to discuss.
Okay, we have a question to you here, to Dr. Lalezari. Based on your existing data, what time point do you believe the drug should be initiated? And how can the drug be introduced to further hospitals to be involved in clinical trials? Finally,
Again,
yes. Do you see any reversal of chest findings, CT chest findings with this drug? And I'm going to mute myself because there's a lot of ambulance sirens here. Yeah.
Right. So again, I think the use, particularly around the world, where healthcare settings vary, is going to be in patients with something more than mild shortness of breath. Probably around the time where some supplemental oxygen is indicated, that's when you want to give the dose. Dr. Goldberg, I believe, raised the question of giving it too early and causing immune suppression. I'm not sure we're seeing that, but it's a reason not to give everybody the drug too quickly. So anything more than mild shortness of breath. In terms of clinical sites, we have sent drug to Israel, to Tel Shemer, and we got a request from the University of Tehran. And I think we're going to stop there. Our focus is to try and get the clinical studies enrolled in the US as quickly as possible and to engage the FDA in a productive conversation. In terms of chest pathology, all I can tell you is that there are a bunch of patients now who have been extubated within a short period of time. One of them was interviewed, and her story, I spoke with her yesterday. Her name is Samantha, a young woman who was, they had tried remdesivir, IL-6, everything, the plasma, and then they gave her leronlimab. 24 hours later, she was extubated. And her story has been all over the news here from a TV station down in LA, and that was done at UCLA. So although I have no information about CT findings, I can tell you that the patients who are responding rapidly, even when they're critically ill and they're weaning off of oxygen or getting extubated. Again, our success rate in the very critically ill is only 50%, but from what I'm reading, 50% in end-stage patients is pretty good. So it has to be better if we just start a little earlier.
Okay, thank you very, very much. We have a bunch of more questions here on the chat coming up. So if we can go quickly over those. Thank you so much. That's very exciting and optimistic. is from Susie. Is immunity enhanced by supplementing with D3 or vitamin C? Anyone? Nesher, Goldberg?
So there's a lot of discussion going around about all kinds of enhancements: vitamin D, zinc, vitamin C, calcium gluconate. I'm not exactly sure how much a role. I mean, there isn't actually any hard evidence data. We're actually participating in a study looking at zinc, but I don't think there's enough data out there to confirm that right now that they have any active or critical role.
Dr. Goldberg?
Yes, I'm not aware of any data indicating any benefit from any supplements.
Okay. Is it true that the virus has mutated and finding a vaccine will be even more difficult because there are 30 different versions of the virus? About the different versions of the virus? Yeah.
I'm actually aware of only 4 different major mutants, not 30, sorry. And I don't think that they have any significant impact right now. And I think that, first of all, we need to find a vaccine, and then we can start talking about mutations and how difficult it will be. And as Dr. Goldberg said earlier, I think we're still pretty far out from having an active vaccine.
Okay. Goldberg, would you like to add anything to that, or shall I move on?
We just don't know. We just don't know. Even if there are mutations, we might be able to handle them just like with the flu vaccine, where you modify the vaccine every year. If there are major mutations, that might be more difficult, but it's an issue of concern, but we just have to wait and see.
Okay, from our board member, David Kimia. How many people were admitted to Soroka Medical Center with coronavirus, and is it dropping in terms of the number? What do you do for critical patients that is helpful? Dr. Nesher.
So we were pretty fortunate that we are geographically distant from the central epicenters that were in Israel. So the amount of patients that we saw in our hospital was relatively low. To this point, we had almost 70 patients admitted, and we had in our ICU, I think it was just 10 or 11 of them. We had a local outbreak in an elderly home that was pretty lethal, because we had a lot of patients, 95, 96, 98-year-old patients were admitted. And it's very difficult to try and reverse the disease at that age with so many confounding illnesses. But we were not hit as hard, which I'm very happy, because as you all recall or know, we're very distant from the other parts of Israel, and we're the only game in town. We're the only hospital in an 80-mile radius. So basically, we don't have anyone to support us. We're the only game in town, as I said, and at this point, it's benefited us. We haven't seen a lot of spillover, but we are still prepared to receive quite a lot of patients if needed.
Okay, thank you very much. And the connection with other diseases and risk factor. There's a question here that experts talk about cardiovascular disease as a high risk factor, and also sleep disorder as a high risk factor. Can you say whether both or either is related, and how those who have that risk should address it?
Certainly people with cardiovascular disease are at high risk for complications. People with lung disease, emphysema, history of lung cancer, other lung disorders are at high risk. Those with diabetes, high blood pressure, obesity appears to be a very important risk factor. I was not aware that sleep disorders like sleep apnea are a risk factor, but that would certainly make sense because it is an issue of respiration. I was not aware of that, but it would certainly make sense. And of course, just age by itself, even if you're healthy, if you're in your 70s or 80s especially, you're much more likely to get into trouble.
Dr. Nesher, and you can also relate to the fact that almost everyone, a lot of people now have sleeping difficulty because of stress and anxiety in the situation. So
yes, absolutely. But I think I'm not aware, as Dr. Goldberg said, about sleeping or anxiety issues as part of a risk factor. But I do know that I think it's all about balance. Younger people, healthier people have a much more stable balance of their systems. And the older you get and the more sick you are, the balance is difficult to achieve. People with heart conditions and so forth, and even a mild cytokine storm or even just a mild cytokine effect causes them to become totally imbalanced. That basically is what kills them off. And that's why we are so excited about something that will be able to affect this cytokine storm. It's the ability of just even look at a simple bacterial pneumonia. A 16-year-old or a 20-year-old healthy person will be very sick, but he will pass it much easier than an 80 or a 90-year-old, especially if he has other heart conditions, lung diseases, and so forth. So it's just the amount of reserve the body has in order to handle and deal with such an ordeal that this coronavirus causes the body.
So we're hearing from you that there's still a ways to go, even though there's progress and light at the end of the tunnel. But there is a question here: as communities open and businesses go back and we visit our families more, what is the best personal protection protocol that we should follow? Because we hear a lot of things about masks, gloves. What is your opinion from your perspective about personal protection?
So in my opinion, I think the Far East has it figured out pretty nicely, much clearer and earlier than the West has. This is a droplet disease. It goes through droplets. So I think that a mask indeed has a part of it. Hygiene etiquette, also coughing, sneezing, hand hygiene, habits of touching your face, habits of touching a guardrail or a community thing or something like doorknobs and so forth that someone else touched earlier, and then touching your own face. So basically hand hygiene and indeed using masks. I'm actually a believer in using masks, even though Western medicine is not. I mean, you've seen a lot of people in the Far East have been using masks for other reasons, for health reasons, for smog issues and so forth, but they also work for this. So I am a firm believer in masks, actually, especially while we still have this running around. And I think the most important thing is not going to work if you're sick, not going to visit other people if you're sick, and staying at home if you're sick. And that's an important issue.
Thank you very much. Dr. Goldberg, would you like to add anything to that?
I don't have much to add. I agree completely about the importance of wearing masks, especially when you're in public places. And we have a law now in New York that we're supposed to wear them. And still, when you go outside, it's amazing how many people are not wearing masks. So that's important. Unfortunately, handshaking, which has always been part of our relationship, and even hugging and kissing people, we just have to back off on that. But it's just very close attention to hygiene. And even if that doesn't eliminate the spread completely, it might cut it down by 90% or so. And that makes a huge difference.
Thank you. And there's a question here to me privately here to ask either one of you. Can you discuss problems with blood clotting in very ill patients, please?
Dr. Goldberg, do you want to start with that one? Or?
Sure, it's just that it definitely occurs. We don't understand why. It's not the most common complication of coronavirus illness, but clearly people have problems with blood clots. They can develop blood clots in their lungs, which can be fatal. It's known as pulmonary embolism. They can develop blood clots in their coronary arteries, which can lead to a heart attack, and they're at risk for strokes. We don't understand it yet. I don't think anyone is ready to give everybody with coronavirus a blood thinner, although we may start to think about that. But it's clearly, it's a well-recognized and severe complication.
I totally agree. And I think that people have to understand that right now what we're seeing in the medical community and in the medical literature is what I think and I like to call is the medical community thinking out loud. I mean, we don't have a lot of hard evidence. This is a very sneaky virus. We're still learning about its complications. We're still learning about the issues that it can cause. There's a lot of reports and a lot of things about that. I think that as everything is, you don't need, we can't jump at everything at the same time. I mean, there's some patients who have clotting issues and other patients who have other issues. And I think that we'll be much smarter and know much better about this disease in a few months and probably coming into the next winter. And right now, there's a lot of reports about a lot of things, and a lot of them are contradictory to each other. And I don't think that we're ready right now to start giving blood thinners to everyone, but definitely clots, especially microclot, may have a role in some of the disease.
So there's another question here to Dr. Nesher. You may be rural in terms of, you know, crowdness, but you have very complex and diverse population, including the Gaza Strip and Arabs, Jews. What is your approach, and how has Israel and Soroka been interacted with the Arabs in the West Bank and Gaza about COVID-19? What has been the role of Soroka in it?
So first of all, absolutely, Israel is a very complex and very diverse country with many different populations, with many different customs. In the Negev area, we have 30% Bedouins in the Negev who have a totally nomadic lifestyle, live in tents. Isolation for a family or a community that lives in tents is a whole new challenge. How to explain isolation? How do you create social distancing and isolation in such conditions? We have communities of secular Jews who live together also very tightly, and they don't connect to the internet, to the social networking. Some of them didn't even know about the coronavirus and the rules and things that need to be done. So there's a lot of that going on. Our lab is the major central lab for the area. We perform daily between 1,000 to 1,500 tests per day, and we do it for the whole community around us, including tests that come in from the Gaza Strip and from other territories and from the Arab communities and from the Bedouin communities. And we support a lot with testing. We have a lot of discussions and with colleagues and peers and with preparedness, and we're all in the same area, and it affects us all. So definitely there is a lot of interactions, and we monitor the situation very closely. There was a wedding just like 4 or 5 days ago, one of the Bedouin communities with over 500 people attending the wedding, even though there was supposed to be, so all these things are things that we monitor closely and work with them on education and so forth. And it's a challenge. It's definitely, we see a lot of challenges in our area.
Thank you very much. So this is a perfect opportunity to say that American Friends of Soroka Medical Center support Soroka and the peaceful coexistence and the care. And right now we have a response crowdfunding campaign that I'm happy to share that we're 75% achieving our goal. We just need 25% more for urgent equipment for COVID-19 that not only help the patients, but protect better the medical staff. So I'm gonna put it soroka.org/COVID. And I would really encourage anybody to make a donation of any level. It's great coming together, everybody, and supporting. And I'm happy to say that we're approaching also 100% participation from our board. So thank you so much. The next question here is again about, you know, the population protecting themselves. Is there any difference between types of mask? There's a mask here, copper infused mask made by Israel invention, or other type of mask, or any type of, even the self-made cloth masks, are they as effective for people who are just in their homes? Any type of mask that you recommend?
I think you have to distinguish between masks that you wear to protect yourself so you don't get infected by someone else, and a mask that you're wearing so that you don't give it to someone else. One of the unpleasant aspects and somewhat surprising about this virus is that people can be infectious, quite infectious, even when they're totally asymptomatic. So the reason that there is a general recommendation now in places like New York for everyone to wear a mask in public places is not to protect you from others, it's to protect other people from you. It's in order to block these respiratory droplets that Dr. Nesher was talking about. So in terms of blocking the respiratory droplets so you don't infect other people, almost any kind of mask is fine. You can just take a scarf or a bandana, and that will block these respiratory droplets. If you're a doctor in the emergency room who's trying to protect himself or herself from other people, there are these special masks known as the N95 masks that are particularly effective. But if all you're doing is wearing a mask outdoors so you don't infect other people, almost any of these homemade masks, to my knowledge, should be adequate.
Thank you very much, Dr. Nesher.
I totally agree, and I wanted to elaborate on the two important points. Is that masks, especially in the public, do not protect you; they protect the others. So you still need to keep all the other hand hygienes and not shaking the hands, and all the other practices need to be there. And furthermore, wearing an N95 mask all day long, if someone is able to get one, is also not recommended. I don't know how much people have experience in using it, but N95s are very difficult to wear and use on a continuous basis. And then what happens is, because they're uncomfortable and they're taxing, and they add to the work of the breathing labor, people mostly have them around their neck instead of having them on their face. So leave the N95s for people that actually treat or come in direct contact with corona patients. What you need is to wear any type of face shield, scarf, mask in order to protect the others. And the way to protect yourself is to maintain good practices of hand hygiene and distances.
So since you said that there are some people that have coronavirus, but they're asymptomatic, we're having a lot of conversations here, you know, offline, that is it realistic to expect from people to, like, even not touch, hug, and kiss their family members at home, their immediate, and also what's the ratio of asymptomatic people? Do we know anything about that?
I think,
first of all, okay, Dr. Goldberg, please go ahead.
No, please.
So what we actually don't know what the rate of asymptomatic people are and how infective they are. It's obviously impossible not to come in close contact with a close circle of people you live with. The first family, the nuclear family, the relatives, the very close people that you live with, obviously you need to hug with them, you need to kiss them with them. If one of the people within your nuclear family unit will become ill, you probably will be exposed as well. And you can't expect to isolate yourself within your own home effectively for a long period of time. I mean, obviously, if you're acutely ill, yes, but on a regular day-to-day basis, it's simply impractical. But you need to keep and maintain the practices on the street, meeting with people, not with the people you live within your own household. That's the thing that needs to be a bit more distance, especially protecting the grandparents and so forth.
Yes, the question that I'm asked almost every day is, when is this going to end? When can I hug my grandchildren? Or when can I hug my grandma or grandpa? And I think the answer is it's going to be very gradual. And obviously, at some point, we do need to hug and kiss people. I attended a virtual Shiva, which was one of the more awful experiences. Awful because somebody died. But if there's one time when you want to hug somebody, it's a Shiva. And doing a video Shiva doesn't really make it. But it's going to be gradual. And it's going to be, at some point, we'll get some sort of vaccine, but it won't be 100%. So we'll know there's still some vulnerability. More and more of us will find out we've got antibodies that will probably give you some protection, but not 100%. There will be some treatments out there. Hopefully the one that we just heard about from California, and there's others that are being developed. And so we'll have the reassurance that if we do get sick, it's less likely to be a death sentence. But all of these things will gradually reduce our risk, but they're not going to eliminate it. And it's, for the foreseeable future, is going to permeate our daily lives. So when you want to go out to eat, you'll ask yourself not just how good is the food and how much does it cost, but how far apart are the tables? And are the waitresses and the waiters wearing masks, or are they not? So I think it's going to be part of our decision-making in a way that the cost of things, the inconvenience of things has been part. It's going to be part of it, and I think it's going to gradually get better. I am optimistic about it, but it's going to be gradual, and will we ever go back to the way it was before? It's just too soon to say.
Thank you, Dr. Goldberg. Dr. Nesher, do you want to add anything about the gradual going back to our daily, not only touching, but also traveling and, our daily interaction?
I totally agree. I think that people with an expectation that this is going to be a short-term thing, and within the upcoming summer, we're going to be flying everywhere for vacation and so forth. I'm not sure that's going to happen. I think Corona is going to be with us for a while. It's going to take a while for us to get used to it. I think the world has changed, and it's going to change. And I think the way that we practice medicine is changing. I think the way that we live is changing. I think our hobbies are going to be changing. I think everything is going to be impacted. And I think that things will slowly and gradually go back to what we are familiar with, the normal that was before. But it's not going to be within the next 4 or 5 weeks or month or two, or even longer than that. I mean, it's going to be a gradual process, and people need to process that the world is going to be a bit different than what they were used to before.
So we're already 6 minutes over time, and I do really thank you for your participation, and Dr. Goldberg the second time. Some of the questions I see on the chat have been answered in previous Ask the Experts. So I highly suggest to go to Soroka.org, and right there on the homepage, we have a recording of our previous sessions, and there are some answers to that. Now, I want to ask a more personal question, and what are you most hopeful and proud of? It can be 2 different questions or one, going forward about COVID-19. Or about also, what are you most proud of? Open question. Who wants to go first?
I mean, the heroism and the selflessness of so many people. We all know about the people working in the emergency room, in the ICU, people who knowingly put themselves in harm's way. And I've seen many, many healthcare providers who have coronavirus, even though they were wearing all the personal protective equipment. I see so many people getting together. I know my neighbor was heading to the grocery store the other day, knocked on my door and said, "Would you like me to pick up anything for you?" I mean, it's a little thing, it's not a big thing, but many people are watching out for each other in a way that they never did before. On the other hand, you also see examples of just extraordinary selfishness. I mean, it cuts both ways. I mean, we've all read stories of wartime and how it brings out the best and worst in people. And it's really like wartime. And maybe I'm an optimist, but what I seem to be seeing more is the really good side, the brave, courageous, selfless acts. And I'm just seeing a lot of them every day.
Thank you.
I would agree, and I would further say that I am extremely proud of the way our hospitals responded. I mean, it was amazing. I'm not sure how many people understand. Soroka is a huge hospital. It's a 1,100 plus beds, and within, I think it took about a week and a half to 2 weeks, everybody just dropped everything, pulled together, and the hospital was transformed to be able to give high quality care to hundreds of corona patients if they would be walking in through the door, including increasing our ICU capacity. And everyone just pulled together, not just the medical teams in the ER, but from almost everyone in the hospital came up and said, what can we do to help? What extra time can we put in? We'll volunteer our time, we'll volunteer our efforts, from everything from taking care of the children of the physicians and the nurses, enabling them to be sure that they're safe and in good hands while they treat patients. So you're saying, the home front is fine, because all the schools and kindergartens, everything was closed very early on. And a lot of the nurses and physicians, especially the younger ones, have young children. And how care of patients when they're not sure about what's going on with their own kids and who's treating them and who's handling them and taking care of them. And a lot of the hospital just came together with a lot of volunteer work and so forth to be able to safely, almost in any field you touch. And that was very heartwarming to see how the whole community, because Soroka Hospital is like a community. It's like a kibbutz, actually. It's 5,000 people, and everyone just came together to help get ready for this event.
Thank you so much. We can just imagine what gives you guys strength and support, because you guys are truly inspiring. You're in the front line. You see this and you take care of so many of us, the global village, one at a time, every day. And so until next time, and thank you so much for coming and participating here and joining. And next time I'll be asking you about what gives you support in all of this, because you sure are doing a phenomenal job for all of us. Thank you so much. And everybody have a great weekend. In Israel, they're counting the weekend on Thursday night, right? Starts the weekend. And toda rabah, and take care, everybody.
Thank you, everyone.
Thank you. Thank you very much.
Thank you, Dr. Nesher, Dr. Goldberg.